Okay, we're going to move on with a diagram of what HELP preeclampsia is in relation to the other diagram that I showed you, the subsets of it. But here we have hypertension, ureteral placental spasm, and so we can have an IUGR baby simply because we're not getting the blood flow. And IUGR again is intrauterine growth restriction, so small for age baby. Glomerular damage, we have increased plasma, uric acid, and creatinine, and we have oliguria. We don't have the perfusion that we need through the glomeruli. Vasospasm, decreased organ perfusion. We've got cortical brain spasms. That's what, there's a lot of blood in the brain. We know that. That's what causes the headaches, hyperreflexia, seizure activity, unless we can quiet everything with our mag sulfate, and I'll get to that. Retinal arterial spasm, it causes the blurred vision. Then the scotoma, hyperlipidemia, well, that's secondary at this point. And liver ischemia, a lot of blood in the liver also. That's where we get the elevated liver enzymes, nausea and vomiting, epigastric pain. We know whenever we have ischemia, we have pain. And right upper quadrant pain because that's where the liver is. So basically, all of this is caused by these spasms due to hypertension and vasospasms with, decreased blood going to the organs. The hemolysis of red blood cells, this is all HELP. Intravascular coagulation because of what's going on here. We've got platelet adhesions, a low platelet count that they quite often go into DIC, which we've already talked about extensively, and increased factor 8 antigen, which is not helping anything in this arena. Increased permeability and capillary leakage, and this all has to do with the kidney, proteinuria, generalized edema, where third spacing fluid can go into pulmonary edema, so they're very short of breath and can't breathe. And then hemoconcentration is elevated because of all the fluid, so we've got an increased hematocrit. So it's, in a nutshell, if you want to look at HELP and problems with hypertension in the pregnant lady, just come to this, and it tells you all of it. A triad of symptoms with preeclampsia, you can put that in here, is edema and weight gain. We already said they are 4.4 pounds a week, which we know is just an insane amount of weight. If they're supposed to gain 25 for the whole pregnancy and they're doing this in the second and third trimesters, they are going to, blow up like a balloon. So usually these three together makes preeclampsia: edema, weight gain, hypertension, and proteinuria. And how much spillage, whether it's +1, +2, is how we get the severe, mild to severe preeclampsia. So for edema, swelling is more suggested of gestational hypertension. If it's in the center of the face rather than peripheral, then we're looking at one of these other conditions. Maintain bed rest. We're going to encourage side lying position, and we know it's the left side, right, to better oxygenate the fetus. Avoid foods high in sodium, caffeine, obviously the vasoconstrictors, and with sodium it would be fluid. They've already got all this excess fluid, so increase food intake to 8 glasses of water a day. Put side rails up for seizure precautions because they are going to be dehydrated. The fluid's not going where it's supposed to be, even though these aren't like heart patients where you're going to put them on a fluid restriction. Treatment. Preeclampsia, we're going to put them on mag sulfate. And I don't know if you remember from our patho, but magnesium is the central nervous system stabilizer, and we don't want these women to seize. We don't want them to proceed from preeclampsia to eclampsia. We want it stopped. So, but mag sulfate, knowing we're going to relax everything, we need to know what mag sulfate toxicity looks like and what's the antidote. What are we going to give? Because a lot of times when these women are this sick, they'll go ahead and give them a bolus of mag sulfate, and you have to stay right there with the patient. Number one, they will have a very flushed feeling in their face. It's hot and it's red. They look red, very, very red, like a bad sunburn. And they'll tell you, oh my God, I'm reacting to this. This is horrible. So you need to tell them before you give it. You're going to feel a very hot feeling, flush feeling in your face, but it's okay, and I'm going to stay right here with you till it goes away, because it does. It subsides quickly. But anyway, So we're going to, again, inform the client of initially feeling flushed, hot, sedated with the mag sulfate bolus. We're going to monitor that client's blood pressure, pulse, respiratory rate, the deep tendon reflexes, and definitely the respiratory rate and the level of consciousness. Because if that respiratory rate goes at 10 or under, we need to notify the physician and pretty much back off the infusion, which we can't stop because we don't want them to seize. But we've got to stay with the patient and notify the physician. They'll usually just knock it back a little bit. They will not take it off. But we can't have them going 8 and under for respirations, not only for themselves and their own organs, and here they're already very, very ill. We've got to look out for the baby at this point. So these are definitely 1-to-1. Sometimes they're 1-to-2, where you have 2 nurses working with them instead of just one. Urinary output, usually we have a Foley catheter in there because of the protein spillage. We've got glomerular pathology going on at the time. And so we've got to keep that urine, we've got to keep the kidney functioning. We know we don't, and the kidney's a tough organ. It can do it, but it's also being deprived right now of blood. So they do have oliguria. Once on magnesium, we need to put a Foley catheter in. We need to know what the hourly outputs are. We're going to look for presence of a headache, visual disturbances. That means things are getting worse. With the hypertension, especially when we looked at back here, blurred vision, it's getting worse. It's not stabilizing. Epigastric pain, we're going to look for that because that means the liver is not calming down either. Uterine contractions at this point, who knows? Fetal heart rate, we definitely need to know what the baby is doing when we're sedating the mom like this. And depending on how bad they get, they'll be pushing fluids in the beginning. If she does proceed into severe eclampsia where we're on magnesium sulfate, they may put them on a fluid restriction. It just depends on how high that blood pressure goes. I've seen them come in, you guys, at 220 over 100 or 110. It's like a stroke in the making. I mean, we've got to move fast. And with those folks, we're not going to give them any fluids. So you're walking this fine line with these folks. But we want to maintain the blood pressure as low as we can get it. We want to maintain the urine output at least 30 cc's an hour. And we want to maintain their reflexes. If we wipe out the reflexes altogether, we're probably giving them too much of the mag sulfate. And 10-to-1, the respirations are going down too. So we know normal respiratory rate for any adult is 12 to 20. And most of these docs will let them go to 10. But again, they're on a monitor. You need to monitor very closely. We don't want it going to 8 because then they're not getting the oxygen they need. I think I covered all of it. Mag sulfate is the medication choice as an anticonvulsant agent, or to stop. Hopefully, we don't want them to go into eclampsia, convulsions, and seizing. It will lower the blood pressure too, but I want you to know that the primary outcome of giving a woman mag sulfate is not that we lower the blood pressure. That's what students always pick. It does. Not all the time, but most of the time it will lower the blood pressure. However, we're giving mag sulfate so that they experience no seizing. That's what we want to do. Okay, pitting edema, we know, leaves a dent in the skin after you press the area with your finger for about 5 seconds. The dent will slowly fill back in. Non-pitting edema does not leave this type of dent. So we're going to definitely chart that. What does that look like? And here we go. There's 1+, 2+ is over here, a little bit further, 3+, and here's 4. And a lot of these folks look like that, unfortunately. And then here's just another way to look at it. 2 millimeters, 4, 6, and 8 as 4+. And as they get into severe preeclampsia, they're on this end. And again, it's just another way to look at it, depending on, which one you like. Minimal lower extremity, marked lower extremity. And when you get in here, you're looking at 3 and 4 edema. You're looking at centralized in the lower extremities, face, hands, and the sacrum, generalized edema, and ascites. And these folks, it's much easier to pick up ascites in another type of adult rather than these guys. Okay, I got a question for you. What do you think of this? We've got a client, she's G3, P2, she's 39 weeks gestation, Presented a high-risk labor and delivery triage an hour ago. Today, her blood pressure was sky high, and she presents to the triage area with complaints of severe headache and spots in my vision. Would you not move on this one? Absolutely. She's getting central nervous system involvement. This is sky high for somebody who is almost ready to deliver. Her cervical exam is 2 centimeters. She's 80% effaced, only dilated to 2 and -2, so she's high, firm mid position. So what type of pregnancy disorder do you suspect that she has? What do you think? And what other priority information is important for the nurse to assess and gather? What do you think we should be looking at? She most likely just looking at her because of the spillage of, did they say anything about protein? Not yet. That's one of the first things I would do is check her for protein. But the fact that this is sky high, I would think that she has preeclampsia at this point. But I don't know if it's mild or severe. We'd have to see about what her baseline pressure is, and we also have to see how much she's spilling in urine. And we know she's over 20 weeks. So at this point, the only cure, you guys, for preeclampsia is to deliver the baby. It's the only way you get rid of it. It's a condition only for pregnancy. So the only way it stops, and a lot of times they have to be on mag sulfate postpartum for a while, but the only way to stop it is to deliver the baby. But we would need, at this point, we would need to draw serum creatinine, platelet counts, liver enzymes to rule out any type of HELLP syndrome. Does she have abdominal pain? No abdominal pain, so that's good. But I would draw that anyway, liver enzymes. And we need a 24-hour urine for protein assessment, but we could actually dip the urine anyway. Yeah, that's about it for that one. And this, I'm going to have to shut this thing off. Let's see, what is this one? Provider orders mag sulfate, 2 grams. What is this medication for? And so I think you could tell me what this medication is for at this point, and we can talk about that in class. Let's see if I have any others. Let's see. Concentrated for the past 2 days. She also states her face seems more swollen than usual. What would be the nurse's first action? What do you think you would do? Obtain a urine sample, place the client in fetal heart monitor, notify the physician of the client's concerns, or take the client's blood pressure. In this area, this would be the correct answer, D. You're going to take the client's blood pressure because if it's low, we're going to be looking at something else. But we know that preeclampsia, all of this starts with an elevated blood pressure according to what her baseline is. So this one is incorrect because it should be determined if there is protein or albumin spillover as a result of reduced kidney perfusion, but this can be done after. We don't need to do this if the blood pressure is okay. What's this one say? Yeah, we're going to end up doing that, but we're not going to do it first. And remember, NCLEX questions are all about priority. And we're definitely going to notify the physician. Somebody's going to notify them that they're there anyway. So, okay, I think that's all I have. All right, you guys, I hope that this made sense to you. This is not the lecture I like to do taped, but there you have it. You can listen to it over and over and definitely ask me all the questions you need. Hopefully, I did not react to the second immunization, and you will see me on Monday. If not, you've got these videos. So anyway, have a great day. Talk to you soon. Bye-bye.